Hi, everybody. It's Dr. Valerie Flores from San Diego Fertility Center, and I have with me Dr. Marc Sklar from Reproductive Wellness. We're really excited for this evening's webinar. It looks like we already have a few people who have joined the webinar. So we'll give it a few more minutes to give people some time, and then we'll go ahead and get started. Okay. Okay, great. It looks like we have a good number, so we'll go ahead and get started. And before I forget, for the live attendees, we are offering free consults, both Dr. Sklar and I, for our clinics. So thank you again, everybody, for joining. And then just a reminder, I'm Dr. Valerie Flores from San Diego Fertility Center. I'm a reproductive endocrinologist and infertility specialist, and the former past chair of the Endometriosis Special Interest Group of ASRM. I also am still thankfully involved in some clinical research at my prior institution, Yale, and so it's really exciting, all of that research related to endometriosis. So I'm really particularly excited about this talk, and even more excited to have with me Dr. Marc Sklar from Reproductive Wellness. I'll let you introduce yourself, Dr. Sklar.
Yeah, thanks so much for having me. I've been in practice for a little over 22 years, all of which with my clinic, Reproductive Wellness, where we specialize in reproductive health and fertility. Something that I like to mention is about 50% of our patients that we support through their fertility journey are trying to conceive naturally, and the other 50% are trying to conceive with IVF or IUI. And so we work collaboratively with San Diego Fertility Center and Dr. Flores, and also to support patients who are trying to conceive on their own. And endometriosis is something that we see quite often, which is why we're having this conversation and this topic today.
Yes, exactly. That's a great segue into our discussion. So I'm going to go ahead and share my screen. Okay. Great. So today we'll be talking about endometriosis and fertility, both from the REI perspective as well as from the Eastern medicine acupuncturist perspective, because we really want to highlight how important it is to have whole body care. We'll start by going through a bit about the epidemiology. Endometriosis affects 1 in 10 reproductive aged women, up to 80% of individuals with pelvic pain, 50% of women with infertility. And while we have long thought of endometriosis as a pelvic disease, we are learning more and more that it's profoundly more than a pelvic disease. It is a chronic systemic disease with multifactorial effects throughout the body, and it contributes to about $22 billion worth of annual healthcare costs in the US. It's equally important to recognize that this condition affects women at a formative time in their career and their education. So really, we do need to focus on how to improve that potential for women, because it can be hindered by delays in diagnosis. So what exactly is endometriosis? We define it as endometrial-like tissue outside of the uterus. And one of the most common theories for how endometriosis develops is that of Sampson's theory of retrograde menstruation, where we see that normally during a menstrual cycle or during menstrual bleeding, the blood is supposed to go out through the vagina. However, in endometriosis, what can happen is that the blood refluxes back through the fallopian tubes and can implant on different areas of the pelvis. And because it's like the lining of the uterus, it can also grow and shed in response to hormones, but there unfortunately isn't a place for it to go. And so over time, it can cause pain, inflammation, infertility. But there still exist many challenges in diagnosing this condition. Dr. Sklar and I were just talking a little bit ago about how sometimes we still see patients have seen several other providers before they ultimately get this diagnosis. And even now in 2025, it can take up to 11 years from symptom onset to diagnosis and treatment. A lot of times providers are not aware of the disease, and so we've really been focusing on increasing awareness both from a patient empowerment perspective as well as for other specialists and other providers as well. And it's challenging sometimes because the symptoms aren't always specific and can be associated with other conditions as well. Pain in and of itself is subjective. Not everyone's pain is the same. And sometimes social norms really inhibit the conversation. I've had many times where patients say, my mom had painful periods, my sister had painful periods. I just thought that that was the way it was supposed to be. But what we'll talk a lot about today is how that's not normal. And so seeking evaluation sooner rather than later is ideal. But it is a real concern because in a survey of over 7,000 women, over 65% were misdiagnosed, and almost 50% saw over 5 providers to ultimately receive the correct diagnosis. And this is problematic because really with early diagnosis and treatment, we can reduce the uncertainty, the discomfort, the disease progression, and later complications. We do have effective treatments. Dr. Sklar and I will both talk about how we treat endo from our relative perspectives. And so this is something that we need to work on improving for patients and providers alike. I did also want to briefly touch on endometriosis in adolescents because I know earlier I talked about how this affects women in their reproductive years. Typically, we think 30s plus, but the reality is some patients are probably developing endometriosis in their teens. So we can see it in up to 40% of adolescents with chronic pelvic pain. In patients who have a laparoscopy for other indications, it can be present in up to 75% of adolescents. And again, about 2/3 of women actually, if you ask them, will say their pain began before the age of 20. So really focusing not just on the 30-plus-year-olds, but also thinking about adolescents and how they describe their menstrual cycles and the pain that they have. There are some known risk factors with endometriosis. One is a history of early menarche. Another is a family history of endometriosis. So in patients who have a first-degree relative with endo, they are 7 times more likely to have endometriosis. Right now, there's no endometriosis gene, but we do see that it can run in families. And another risk factor are shorter menstrual cycles as well. But like I mentioned before, the clinical presentation can be quite varied. Some patients have pain, some patients present with infertility, and actually some patients are completely asymptomatic. So the question really is, why can the symptoms be nonspecific, and why is endometriosis difficult to diagnose? And it really has to do with the complex systemic nature of endometriosis, which I want to talk to you all about next. So like I mentioned, the most common theory for endometriosis is that of retrograde menstruation. So the lining of the uterus ends up in the pelvis, and even though normally the immune system is supposed to clear that, for some reason that tissue sticks around and develops into the endometrial-like tissue that we call endometriosis. But that doesn't explain all cases, and what we've been learning is that there are probably other ways that endometriosis develops. One of those can be from the bone marrow. The bone marrow has a variety, has stem cells, and they can ultimately become a variety of different types of cells, one of which are endometrial cells. And so a newer theory is that perhaps there's an endometrial cell, or there's a stem cell that was supposed to become an endometrial cell and then somehow ends up in the pelvis and develops into endometriosis. And we also know that these endometriotic lesions themselves can either have stem cells or can actually create these small molecules that can travel to distant organs. And so that's how we've actually started learning a little bit more about not just the circulating factors involved in the pathogenesis, but how these circulating factors can also contribute to endometriosis. We do see inflammation related to endometriosis. We see individuals have a lower BMI. We see altered pain perception and mood disorders, and we see infertility. But how is all of that happening? And so that's what I meant when I said we're really learning that it's not just a pelvic disease, it's much beyond that. And so we think that these small molecules, we call them microRNAs, but that these small molecules and these inflammatory cytokines are affecting various organs, the liver, the brain, the lung, fat cells, and the endometriotic lesions themselves, as well as the endometrium or the lining of the uterus. One common misconception about endometriosis was that individuals who were thin were at risk of having endometriosis, but it's actually the complete opposite. The endometriosis itself has been found to affect areas of the liver associated with metabolism, and so it's the endo really that's contributing to this lower BMI. The same when we talk about mood disorders and pain perception. One, the endometriotic lesions themselves recruit nerve fibers to that area, so pain sensitization locally is altered. And on top of that, there have been studies showing that there are areas of the brain associated with anxiety, depression, pain perception that really are altered. And so again, it really can have systemic effects. And so when we talk to patients, we really have to focus on that whole body approach. Yes, they may be seeking fertility or pain management, but really it's a whole systems issue that we need to address for these patients. So what we see in the pelvis is truly just the tip of the iceberg. We're learning more and more that although we typically talk about pain and infertility, we know that it can contribute to depression, fatigue, decreased quality of life, cardiovascular disease, and then some of the other symptoms that can go along with cyclic pain like bowel dysfunction, bladder dysfunction, and of course the inflammation that we've talked about as well. Now, I do want to talk a little bit more about how endometriosis can affect fertility. So as I mentioned, we do know that the prevalence of endometriosis increases up to 50% in women with infertility, but how exactly is the endo causing that? It's a couple of different mechanisms. One, it can be changing the lining of the uterus. So normally in preparation for ovulation, we see higher levels of estrogen or increasing levels of estrogen that causes the lining to thicken. Ultimately, progesterone comes on board after ovulation that helps stabilize the lining and prepare it for implantation. But because of that endometriosis, sometimes those normal signals don't happen and we don't always see the uterus undergoing the changes it needs to undergo for implantation. So that's one way it can cause or contribute to infertility. The other is inflammation. We know that that can negatively affect the ovaries or the eggs. And another way is actually through tubal transport. So normally the egg and the sperm meet in the fallopian tube, but this can be affected. Sperm transport in particular can be negatively affected by the presence of endometriosis. Now, I don't say this to say that patients with endo cannot get pregnant. I just mentioned this just so you know what we're thinking about when we're talking about the different treatment options and alternative care that we can provide to help lower the inflammation and optimize your likelihood of pregnancy. And then the other thing that I wanted to mention, overall a positive, but even though we do see that endometriosis can affect egg quality and egg quantity, it's important to recognize that overall that does not translate to more abnormal embryos. So it's kind of a busy figure here, but essentially what it's showing is that when patients who underwent IVF and had their embryos tested to see if they were chromosomally normal, the presence of endo did not contribute to a higher likelihood of abnormal embryos. There was the same number of normal versus abnormal whether you had endo or not. So yes, we know it's causing inflammation and maybe changing the egg number, but thankfully it doesn't seem to be affecting the quality from the perspective of how many eggs are chromosomally normal. And then I did want to talk a little bit more about the endometrium and how that's affected. So this is kind of going back to the normal fluctuations that happen here on the left side. We see as a follicle is developing, as the egg is maturing, estrogen levels go up. After ovulation, progesterone levels go up, and this is really working to stabilize the endometrium. In endometriosis, what we can see is that for some reason, the uterus doesn't always respond to progesterone as it should. So this is something we term progesterone resistance. And so what this can translate to is a non-receptive endometrium. And so an endometrium that's not always as well prepared for implantation. And we'll talk in a little bit about how we can overcome this and how we can essentially try to reset the uterus to better respond once it's time for implantation. And then in terms of the treatment options that we have available for patients with endometriosis, from the reproductive endocrinologist perspective, first line can be something like ovulation stimulation and intrauterine insemination. What this is doing is one, increasing the number of eggs that are available to be ovulated and ultimately inseminated. And then we're working to overcome some of the issues with the sperm traveling through the uterus to get to the fallopian tube by bringing the sperm closer to the eggs. That's where the intrauterine insemination comes into play. And then always supplementing with additional progesterone if we know that the uterus may not be able to respond appropriately to endogenous progesterone. By giving a little bit extra, hopefully that'll help overcome any progesterone resistance. And then, of course, we also have in vitro fertilization, where we essentially stimulate the ovaries, retrieve the eggs through a vaginal procedure, inseminate them with sperm in our embryology lab, and then watch them develop into embryos. And then usually when we talk about IVF, a big question that I get asked a lot is, should I or a patient be having surgery before undergoing IVF? If we know all about the inflammation that's happening, is that a good idea? And typically we say no, unless we're having trouble accessing the ovary because of endometriosis. Typically we don't recommend surgery just because long-term we do worry about compromising egg quantity. But I'll talk a little bit about how we do now recommend medically suppressing endometriosis before an embryo transfer. So this is something new. It's actually some research that I've been involved with through my work at Yale. So typically when patients undergo IVF, whether they have endometriosis or not, we always do the egg retrieval, inseminate the eggs, watch them develop into embryos. And then when we have an embryo transfer, we typically do what we call a medicated embryo transfer, where we give patients estrogen to help thicken the lining and ultimately add on shots of progesterone to prepare the lining for implantation. But studies have shown that even though IVF is the best treatment we have available, for patients with endo, sometimes the success rates aren't as high as that of patients without endometriosis. And so we took that and said, what is it that we could be changing or optimizing for these patients in particular? And since we know that endometriosis causes inflammation and can make it harder for the uterus to respond appropriately to progesterone, we thought, what if we try to clear out all of that inflammation from endometriosis first, medically, and then from there go into an embryo transfer cycle? And so we did this using a GnRH receptor antagonist. It's called Orilissa. What it does is it lowers estradiol levels, because the big hormone that endometriosis always responds to is estrogen. It loves estrogen, loves to grow in response to estrogen. And so if we can knock out that estrogen, or if we can lower the estrogen level, that essentially will allow us to essentially knock out the endo, knock out that inflammation, and then it will hopefully help reset the uterus to better respond to implantation or progesterone and ultimately implantation of the embryo. This came about from some older studies looking at a different medication, a GnRH receptor agonist, and endometriosis was medically downregulated for a few months. We did see higher clinical pregnancy rates, but the studies kind of stopped there. So this study is taking it a little bit further. Not only do we want to see improvements in clinical pregnancy rates, but ultimately we're looking at live birth rates and whether or not some complications of pregnancy that we know are specific to patients with endo, if those also go away. So this is still an active, ongoing trial, and it's something that is new and exciting that we can offer patients. The last few things I wanted to talk about were more related to the non-invasive diagnostics that we currently have or are in development right now. One of them is imaging, typically ultrasound. I'll talk a little bit about blood markers and also uterine markers. So with imaging, the big thing that I wanted to highlight here, we do have vaginal ultrasounds as well as pelvic MRI. A normal scan does not equal no endometriosis, and that's because we can't always pick up endometriosis on an ultrasound. Unless it's a cyst of endometriosis, many times the ultrasound may look completely normal. And so that's where it can get a little tricky for diagnosis, and where focusing on symptoms is really the more important thing. So a normal ultrasound is really just ruling out other causes of pain, not necessarily ruling out endometriosis. The other thing are some blood markers. This was some work that one of my colleagues at Yale was involved in. So again, we had talked about those microRNAs mediating some of these downstream effects of endometriosis. And so then we started looking at, could we actually use the levels of microRNAs in endo to actually diagnose endometriosis? And so as a combination of microRNAs, it actually had a really good likelihood of diagnosing endometriosis. It was about 94% accurate. It's currently still being studied to actually be available as a test, but it's something exciting for those patients who may not be able to see a specialist. Hopefully this will help shorten the time to diagnosis as well. And then one of the other uterine markers that we will sometimes look at is something called, the test is called Receptiva. So it's looking at a cellular proliferation marker called BCL6. It's increase in the endometrium of patients with endometriosis. And so again, it's a way to potentially help diagnose endometriosis non-invasively. And so on the right-hand side, it's looking at patients, they're looking at the scoring. So essentially how much of this BCL6 is present. And it was found that the BCL6 level was higher in those who had endometriosis. That's these laparoscopy cases here. So that's another test that we offer at our clinic as well. And then the last thing I wanted to talk about was just some work that I've been involved in. I know I talked a lot about progesterone resistance. So I looked at using progesterone receptor, which is how progesterone mediates its activity, as a potential marker for who will or will not respond to progestin-based therapy. So even though progesterone-based therapy is first line for treating endometriosis-associated pain, up to a third of women fail that treatment. And so I really wanted to see if we could develop better ways to be able to tell who would or would not respond, so that we avoid causing more pain or preventing relief of that pain. So I actually looked at, again, how much progesterone receptor was in endometriotic lesions of women who were undergoing surgery for endometriosis. And what I found was that in those who did respond to progestin therapy in the past, they had higher levels of progesterone receptor compared to those who did not respond to progestin-based therapy. That was really nice, but really the question is, can we use it then to diagnose or to determine who will or will not respond? And so then I created essentially a bit of an algorithm to then say, okay, if your progesterone level is this versus this, does that mean that can we predict who will not respond? And so we actually could. We had 3 different scoring systems: a progesterone level over 80, a progesterone level less than 5, and then a group in between. And what we found was that in those with high PR expression, there was a complete response, 100% response rate, which was in stark contrast to those who had low PR expression. There was only a 6% response rate. And even those actually who had medium levels of progesterone receptor, there was actually only a 21% response rate. So this is really helpful because, again, for patients who are not necessarily seeking fertility, sometimes after surgery, they're placed on the same medication that didn't work for them. And so if we can tell them and test them and say, you know what, it looks like you don't have progesterone receptor, it looks like the progesterone medication is not going to work, then we can switch to other estrogen-based therapies, or really estrogen-lowering based therapies, to help optimize their management and prevent recurrence of their pain and endometriosis growth. And this actually relates now to that same medication, or list that I was talking about, that we're using for IVF patients. It actually is already approved for treating endometriosis-associated pain. And so what it's doing is it's basically lowering estrogen levels. There are 2 doses available, a low dose and a high dose. And so we always start with the low dose, but can ultimately increase that if needed to help optimize pain control. And then lastly, this is a medication that's actually approved for menopausal patients who have hot flushes, but we actually looked at giving this for patients with endometriosis. So if we know that endometriosis loves estrogen, well, estrogen binds to its estrogen receptor to mediate all of its activities. And so bazodoxifene is a tissue-selective estrogen receptor modulator when combined with estrogen. And what it does is it actually binds to the estrogen receptor and completely degrades it. So even if there's estrogen around, the endometriosis can't grow because estrogen can't bind to its receptor. So not approved yet for managing endometriosis-associated pain, but is a potential future therapy for patients struggling with endometriosis-related pain. And then lastly, I just kind of wanted to summarize, because I know that was a lot of information. When we think about how we treat patients with endometriosis, the first thing is, what are their goals? Is the goal pain management, or is the goal fertility treatment? Pain management, we still do start with progestin-based therapy, but if that's not working, the important thing is recognizing that we have alternative therapies like Orilissa to treat patients. And then surgery does have a role. It's not that we don't recommend surgery at all, but we usually try to medically manage first before moving on to surgical therapy. But again, it's important to recognize that endo can always come back, and so we always still want to have something available to give patients after surgery. And then, of course, when it comes to infertility treatment, we can start, especially for those who have more mild endometriosis, mild meaning not minimizing your pain, more so if an individual has had surgery that we don't see, thankfully, a lot of endometriosis. We can start with ovulation stimulation and intrauterine insemination. For those with more advanced disease, we do recommend going on to IVF. And I think those are almost the end of my slides. So just to summarize, again, endometriosis-related infertility is common. The symptoms are varied. And so if you think you have endo, we definitely want you to see us. I love referring to Dr. Sklar because he's going to talk all about his perspective and how he manages patients from a holistic approach. And then again, we really have to focus on it being a chronic systemic disease. We do have now new ways, hopefully, to diagnose it, to hopefully help shorten that diagnostic delay. And we have ways to predict who will or will not respond to a given form of therapy. And really, ideally, this precision medicine approach is key. It's really going to help optimize care for patients. And then again, from the perspective of IVF and embryo transfers, we do now have a way to better increase the likelihood of success with IVF for patients struggling with endometriosis. And so with that, I will pass it over to Dr. Sklar. I'll stop sharing my screen. Okay.
Great. Thank you. Let me see if I can get my screen up here. There we go. And then I'm going to hit, there we go, play. All right. So thanks so much, Dr. Flores. We have not done this together before, and so I was listening and interested in all the research you were doing. So that was great. Hopefully everybody watching felt the same way. So this is just a little bit about me. I'm the clinical director of reproductive wellness. I have a YouTube channel called Fertility TV, and I am the past president of ABORM, which is the Oriental Reproductive Medicine Board. So before I get into understanding endometriosis, I want to highlight, previously I said that when we work with patients in the clinic, that many of them are trying to conceive naturally, and then the other half are trying to conceive with either IVF or IUI. When we have endometriosis patients, for us, we can't always know on our side if they haven't been previously diagnosed. We can't always know if they have endometriosis. We can make some assumptions, some guesses, but if we're not working with someone like Dr. Flores, we won't be able to officially diagnose them. And so this is where some of this comes back to the Chinese medicine side of things, because traditionally, when Chinese medicine was created, the theories, they didn't know about endometriosis. They didn't have a disease category for that. So from a Chinese medicine perspective, endometriosis is a whole person disease that has implications in many systems of the body. Just like Dr. Flores said, right? We know that it impacts multiple systems, and many systems are involved. The most obvious are going to be the endocrine system, neurological, immune, and reproductive. But the symptoms are complex, and I agree. Suffering is definitely varied. Pain can be nothing at all. Some can have asymptomatic or silent endometriosis, or it can be very severe. In Chinese medicine, they don't have a disease category technically called endometriosis. It would fall under Tongjing, which is what we classify as dysmenorrhea or painful menstruation. But there are variations or degrees of that, and that's where we start to kind of manage things in different ways depending on the severity of it. So in clinical practice over the last 22 years, what we've seen is about 66% of women with endometriosis, the first symptoms of the disease appear before the age of 20. And that 40% of unexplained infertility does tend to be as a result of endometriosis as well. Something that we've observed in the last 5 years, and I don't really have an explanation for it. I can make some theories and guesses, but we have seen a rise in endometriosis patients in the last 5 years. And just like Dr. Flores had mentioned, unfortunately, many of them have taken many, many years to be diagnosed, which, can be frustrating on many levels. What we have observed over this time is that there's altered follicular genesis, which will possibly lead to varying issues. Some could be ovulatory dysfunctions, irregular ovulation, reduced fertilization rates, abnormal healthy embryos, luteal phase defects, or poor oocyte quality. So in Chinese medicine, this is where things get fun when we start talking about Chinese medicine, is we start using all of our terms for diagnoses, which are foreign on the Western side of things. But this is how we classify any disease category in Chinese medicine, whether this is endometriosis, whether it's a digestive disorder, a lung disorder, they will technically fall into the same patterns that we see here. But because of the symptomology present, let's just say a lung disorder or a GI disorder versus endometriosis, that might impact how we treat the individual, right? So that would impact the acupuncture point selection we choose, or the Chinese herbs we decide to incorporate, or whatnot. So the biggest thing that we see here with all of these different pattern diagnoses is that they invariably lead to poor circulation and pain. So the first one, liver stagnation, this is more having to do with emotional upset, stress, which we know plays a role. Chi stasis is a lack of proper healthy circulation throughout the body. That would also go with the last one on the list, blood stagnation. Heat stagnation stands for itself. It's, accumulation of heat. So this would be someone who might have endometriosis but has more heat signs versus someone who has endometriosis and has more cold signs, which is the next one down. Damp heat we do tend to find with almost all endometriosis patients. And this is basically, if you would imagine, like phlegm congealing. That's how they started to diagnose these sorts of things thousands of years ago. And then the other two, Qi deficiency and Yin deficiency, are a lack of, basically there's lacking in the body. So Qi is like a lack of energy, and Yin is a lack of nourishment or substance. This, in most cases, we're talking about fluid here. So most individuals do not have one of these patterns. They're going to have multiple patterns because we're all complicated and we all have many varying issues in our bodies. And so that's how this gets kind of put together. So over a series of questions, looking at someone's tongue, analyzing their pulse, and their history, we're going to come up with our diagnosis for, what your pattern might be. This pattern diagnosis will lead every decision we make in our office from a Chinese medicine perspective in terms of treatment and how we approach treatment. Other systems that can be impacted and often are, but we wouldn't necessarily see them all, would be digestive issues, obviously the reproductive issues, urinary issues, neuromuscular, endocrine, and nervous system. So this is just an understanding for how acupuncture works. We often get this question of when someone comes into the office and they start to use acupuncture for the first time, well, what is it? How does it work? What's it going to do for me? And how frequently should I expect to be coming in for treatment? The picture on the right side is just a picture of all the different meridians or channels that we utilize when we're addressing and supporting patients. The two main things that we are trying to do in endometriosis patients is improve blood circulation and reduce pain. So those are at the top of the list anytime we're working with endometriosis patients. And the amazing thing is acupuncture is very good at both of those things. I mean, as soon as the acupuncture needles go in, it starts to dilate the blood vessels and circulation happens. And by the point selections that we choose throughout the body, we're then able to tell the body what we want to do. Where do we want to improve circulation? How do we want to do it? So I always kind of refer to this as like coding. I can put code into a computer and just tell it random things to do. But if I want it to do specific things, then I have to be very specific about the coding that I give it. And so acupuncture works in a very similar way. Next, it does regulate the nervous system, which allows us to allow you to relax and calm down. And this also, when we are trying to also support hormone regulation, also allows us to do that through this pathway. Frequency of visits does vary, and part of this variation depends on how much time we have. I'd also say some of the things that I consider when I'm thinking about frequency of visit is the severity of the condition as well, and how quickly we need to see change. But usually we're going to see patients once a week. There are times when we will see patients more than that, twice a week, or in rare occasions, even 3 times a week. Again, if we have a short amount of time, let's just say you said to us, like, we're trying to achieve a certain goal before your IVF transfer in 6 weeks, then we might need to see you more frequently than if you said, my goal is to be pregnant in 6 months. What can we do in that time frame? And so then we're able to stretch out our plan a little bit more. And then the severity of the treatment, the severity of the condition, if the pain is really intense and we're really trying to make some changes in a short period of time, we might want to see more frequently. Or If your pain increases, which often does during menstruation, then we might want to see you a little bit more frequently in that short period of time. Chinese herbs. So we rely on Chinese herbs quite a bit when we are talking about addressing endometriosis, because this is, we're trying to impact the endometrium and break up this tissue, right? So we're going to use a variety of different Chinese herbs. Most of them are meant to increase blood circulation, stop pain, and resolve these cysts. So if we're going to use the Chinese herbs, we're going to use them on a daily basis. You're probably going to take it 2 to 3 times a day. They don't usually look like this picture right here. We have them in various other forms. This is the old-fashioned way in China, where they will give you these herbs to cook up at home. And we still can do that in more severe cases, but usually we're giving you either powders or liquid extracts, or even pills for that matter. And Chinese herbs leave the system relatively quickly, so we do need to take them 2 to 3 times a day for them to be effective. If someone is going through fertility treatments, by the way, we don't typically use Chinese herbs in that situation. This would be something we'd want to use before you're going through IVF, or if we have a little bit of time beforehand to make that, to incorporate them. And this day and age, there's a lot of things you can get throughout the internet. Amazon might even deliver it to your home. I highly recommend not getting or using any Chinese herbs if it has not been prescribed to you by someone who is trained and knows what they're doing, because just because they're natural does not mean that they are not dangerous. And if you're taking the wrong thing, they do have side effects, and they can cause issues. Okay, anytime in our office that we're working with endometriosis patients, yes, we do acupuncture and Chinese herbs, but we do so much more than that as well. And our strengths is incorporating all of these tools together to really make change for patients. So nutrition is something that's extremely important for us, regardless of the severity of the endometriosis. And so aside from acupuncture and herbs, we want to start to make change systemically and constitutionally. And this is something that you can start to do at home, which makes a significant difference, hopefully so that you don't need our services later on. So we would like to, when we do this, we're trying to support your liver. And so adding in some lemon water, leafy greens, eating like the rainbow is really important. We also really want to support digestive function and health and proper elimination. This is important when we start talking about regulating hormones. And so fiber-rich foods, managing insulin levels and eating fermented foods. And then anytime we're talking about inflammation, endometriosis and pain, we're talking about inflammation. And so managing other ways that inflammation can be increased. So managing stress is a big one, incorporating potentially some systemic enzymes, curcumin or turmeric, and then, as I mentioned previously, some herbs. Along the same lines with nutrition, cutting out inflammatory foods, we have seen makes a dramatic difference in managing the pain and inflammation in the body. So some things that you can easily start to do now is reducing refined sugar, which we should all be doing anyway, eliminating or greatly reducing wheat, and same thing for pasteurized dairy products. Caffeine is a big one, and then xenoestrogens, including soy and excessive environmental exposure, such as plastics. So that's something that I have seen over the recent years, and potentially a reason why we've seen an increase in recent years is our exposure to environmental toxins, one of which is plastic. So as we're talking about environmental toxins, this is what the next slide is all about. This is something that I've spent quite a bit of time talking to patients about. We're exposed to upwards of 80,000 environmental toxins on a daily basis. And with that being said, we're not going to be able to eliminate all of them on a daily basis, but we're going to do the best we can. I always talk to patients about just making progress and not being perfect, and we can only do what we can do, but we can do a lot to that point. And so eating organic foods makes a big difference with the quality of the food that you're eating. Sometimes the conversations I'm having with patients is, I don't really care what you eat as long as you're eating good quality food, because quality is very, very important. Avoiding exposure to pesticides, herbicides, and synthetic fertilizers. That's where from your food, organic food come into play, but also just in your environment around, what do you use at home? And then all your personal care products, makeups, avoid food preservatives and dyes as much as possible, use low VOC paints, use recycled unbleached paper products, use non-chlorinated oxygen-based bleach in your laundry, and avoid plastics. And by the way, when I'm mentioning these things right here, especially this like unbleached paper products and organic products, this to me also incorporates tampons and pads as well. That's a big one for me in conversations with patients. And by the way, the other piece that I didn't list here, but I should have when we're talking about environmental toxins, is all the toxins that are now found in our clothing, all the synthetic fibers that we use, especially on athletic wear, that so many of us live in on a regular basis. So I would be careful with those as well. Some supplements that you can start to incorporate, but I really do recommend that you work with myself or a trained professional who understands these before you just start taking them. But NAC has been shown to have some significant benefit, and acetylcysteine on reducing pain with endometriosis. DIM is something that helps manage estrogen levels, and you have to be careful with that one, especially if we're trying to if you're incorporating hormones and doing IVF and whatnot, like that's something you can't just take on your own. I'm often taking patients off of that if they're going through IVF. But to Dr. Flores's point, which is one that is really pertinent when we know that estrogen impacts endometriosis growth, DIM can be beneficial if used appropriately. Systemic enzymes help with circulation and reducing pain, as does curcumin or turmeric. And then pycnogenol is a powerful antioxidant that comes from the bark of a pine tree. It's been shown to help women with endometriosis and improve egg quality. And then bee propolis, as well as a study published in Fertility and Sterility back in 2003 now, showed that 60% of women with endometriosis-related infertility who took 500 milligrams of bee propolis twice a day for 9 months became pregnant, as opposed to 20% in the placebo group. So that's a significant difference between the two groups. Now, again, I will highlight, I don't think there's a one size fits all, and I don't believe when it comes to supplements or herbs that everyone can take the same thing. So for me, it's really important that you're working with someone who knows how to manage this properly and can evaluate your situation and create a customized protocol for your needs based on your situation and what you're doing. And thank you very much. I will stop sharing my screen, and then we can move on to questions.
Thank you so much, Dr. Sklar. That was great. Okay,
Yeah.
so if anybody has questions, if you could please put them in the chat, actually, and then we can go through them from there. I had a question actually, Dr. Sklar, so when you see patients who already come in with a known diagnosis of endometriosis, do you change, or how would you change the acupuncture points in addition to like the supplements and whatnot to take? What are some areas that you focus on for them? And they're seeking fertility.
Yeah, I think some of it comes down to their symptomology. So if they have, if they're having pain or the cyclical nature of the pain, that might determine how the point selection that we're choosing.
Okay.
But for me, when I showed that slide about all the different patterns in Chinese medicine, it's all going to come down to their pattern. So we layer several different things when we're choosing our point selection. We're going to take their Western diagnosis, then we're going to take their Eastern diagnosis, and then we're going to determine where, where they are at their cycle at any given treatment. And that's how we shift our point selection from visit to visit, depending on where they are and what they're doing.
Perfect. Nice.
Yeah.
Okay.
I think Tiffany has a hand up, but I'm hoping she's
Yes.
got a question she can post for us.
Trying to see how to, let's see. Oh, here we go. Let's see. Okay, Tiffany, I think you should be able to chat now. If you unmute yourself. Sorry. Or you can put it in the chat. I do see there is a question in the chat, actually. So I'll answer that one. The question is about experience with patients with endometriosis who are considering egg freezing. So we have, thankfully, a lot of experience, and I have a lot of experience with that just because, yes, we do know that patients with endometriosis can have a lower egg reserve. And on top of that, if you're thinking about having surgery for endometriosis, we always in the back of our minds are worried about any potential negative effect on the ovaries. So egg freezing is a great idea just because it does a couple of things, whether you have endometriosis or not, but particularly for patients with endo, we're taking those eggs out of that inflammatory environment and freezing them in time. So they will always be there at the age that you froze them for future use. Of course, it does mean going through IVF ultimately if you want to use those eggs, but it's definitely a great option for patients who have endometriosis and are concerned about long-term how that's going to affect their egg quantity and quality. So I highly encourage that. Okay, Tiffany, I think you should be able to talk now if you unmute yourself. And if not, again, please feel free to put a question in the chat. Okay, here's another question. How long do you recommend being on Lupron or Orilissa before an embryo transfer if you have advanced stage endometriosis? So great question. We typically recommend for 3 months for Lupron and then 2 months for Orilissa. The reason why Lupron has always been a little bit longer is because it's an intramuscular injection, and the first month you don't really get that full effect of suppressing estrogen levels. So that's why Lupron we recommend for 3 months before an embryo transfer. And then with Orilissa, it has a shorter onset of action. So literally the second you take that first pill, your estrogen levels are dropping within the next 24 hours. So that one, 2 months oral, twice a day medication before an embryo transfer. It's a great question.
Dr. Flores, I have a question for you.
Yeah.
You mentioned in your slides, you really focus on Orilissa.
Mm-hmm.
You didn't mention Lupron. Do you have a preference for Orilissa over Lupron?
I do, mainly
Okay.
because I think it's easier for patients to have to,
Absolutely.
one,
Yeah.
not have to do an injection, and two, waiting. It's already such a long waiting game for them to even get to the point of fertility treatment. And so anything we can do to shorten the time, I think is key for them. So that's why I always prefer the Orilissa over Lupron.
Do you notice different, less side effects with Orilissa?
Not always.
Not always. Okay.
Lupron drops the estrogen levels to about 6 picograms. The Orilissa drops it to about 12. So not always fewer symptoms. It's just, I think, a little bit easier to only do it for 2 months as opposed to 3. Okay, so another question is if I can be the one to diagnose endometriosis or should patient see an OBGYN first. You are always welcome to see me or Dr. Sklar for a diagnosis of endometriosis. It's something that I have been doing since my training. My aunt actually struggled with endometriosis-related infertility, which is how I became interested in the condition. So it's something that I feel very comfortable diagnosing. If you have to see your OBGYN first, it's not that they can't diagnose you. They also get a similar training minus the fellowship part. So you can definitely see them first, but usually they'll refer you to us anyway, just for that specialized care. So you can always make an appointment to see me first.
Yeah, and I'll chime in and just mention that from my side of things, when we're working with patients who have already typically seen their OB and their OBs are not typically diagnosing their endometriosis, I find that you're better off seeing Dr. Flores for something like that then going to your OB, also for getting the proper care as well.
Thanks. And then another question is just about wait time. So I actually offer an evening clinic on Mondays and usually Wednesdays afternoons, but this time, or Wednesday evenings, but this time I wanted to do the webinar. So thankfully it does not take long to get an appointment with me. I recognize that a lot of us have 9 to 5, so it's hard to fit in into getting an appointment during that time. So essentially any day works, but if evenings are better for you, Wednesday and Monday evenings, I have appointments as well. See if there are any questions. Let's see. Oh, here we go.
Yeah.
There's a question about if it's possible for endometriosis symptoms to become worse after surgery. So typically surgery involves clearing out the endometriotic lesions that are there. That being said, one of the risks of surgery, although not particularly common, one of the risks is scar formation after surgery. So typically what can happen is patients may initially have a great pain relief in terms of their endometriosis associated symptoms, but can over time develop pain again. Sometimes it's from the endo coming back. Other times it could be that some scar tissue has formed following the endometriosis surgery. So one consideration before thinking about doing another surgery is to try medical therapy first. It doesn't have to be a long time. It can be a month to 6 weeks. If the pain gets better, great. It could be that the endo was a little more aggressive and started coming back sooner. If the pain doesn't get better, then we think it could be potentially scar tissue that is formed. And so that's when we can potentially think about another surgery. Or again, looking at alternative therapies like acupuncture and Eastern medicine to see if those also help as well. Dr. Sklar, there are 2 areas for questions. I should have mentioned that. Sorry.
Oh no,
One
I
is
knew.
in
I was looking.
okay, good.
Yeah,
I
I
was
was
like,
looking.
I realized I didn't tell you that.
I was looking.
Okay, great. Let's see if there are any other questions. Let's see.
One of the questions that just popped up says, do you have a special protocol for secondary infertility?
Oh, great question. We still do the main workup. We still kind of treat it like primary infertility just because things can change over time. Sometimes patients might be a few years older. Sometimes patients may have had surgery that's affected their fallopian tubes. Sometimes maybe there's some scarring that is formed from a prior pregnancy. So we still do the full workup as if it were primary infertility, but then again, focusing on what might have changed from baby number 1 to now looking for baby number 2. And then another question, oh, let's see, hold on. Yes, another question is about second opinion. So absolutely, you can definitely see me for a second opinion to go through your endometriosis symptoms, have another ultrasound if needed, and then come up with a diagnosis and protocol for you.
These are good questions.
Yeah, these are really good questions. Dr. Sklar, do you see a mix of patients who are coming in for endometriosis associated pain as well as those seeking fertility?
Yes.
Yeah.
Yeah. So we will have, over the years, I've seen plenty of women who have just come in just to manage the pain and the disease, and they weren't interested in getting pregnant at that time. And then obviously with those who are trying to get pregnant as well. Yeah.
Okay, great. Another question is about our location. So we have 3 sites. Our primary clinic is at Del Mar. That's where we complete the egg retrievals and the embryo transfers and where the embryos are stored. And then we have a satellite office in Mission Valley, which is very close to Dr. Sklar.
Mm-hmm.
And then we also have a satellite office in Temecula. So we can see patients both in our Del Mar and our Mission Valley office. Temecula, usually our nurse practitioner is there, but you can always schedule a telemedicine appointment with us if it's a little hard to get to one clinic versus the other. Okay, we'll give a few more minutes to see if any more questions pop up. Let me just double check the other QA spot. Okay. I think I'll talk very slowly. I think those are all the questions. I was like, just giving a little more time in case someone else has a question. But I think that those are all the questions. Again, one, just to thank everybody who came to the webinar. We so appreciate taking time out of your busy schedules. We hope you found this helpful. And then Dr. Sklar, same to you. Thank you so much. I know you're very busy, so to be able to come and do this with us was really just a pleasure. So thank you.
Yeah, I appreciate it. This was fun to do, so I appreciate the invite. Thank you.
Perfect. Hopefully we'll do more.
Yeah, absolutely.
All right. I hope everyone has a great evening.
Bye,
Bye.
everyone.